Hello and welcome to today's teaching by the Surgical Academy. Today we have Dr. Katrina Forsyth, who is covering vascular surgery emergencies. Over to you.
Perfect. Thank you for joining and those watching online. So hopefully some of you might have watched the previous series on common conditions, so I won't go over the bits we've covered there, but let's get started. Okay, so this is our objectives of this session. I know it's quite short, so I want to get to the point and the bits that really are takeaway good facts for you to remember. A little bit at the start about what to do in an emergency, whether that be whether you're on ward cover or whether you're seeing a patient in A&E when you're on call shifts. A few of the common conditions, and then we'll go into a bit more detail on some of the conditions that I think you need to know a little bit about, and you'll see as are likely to ask you questions on. Okay, so A to E. Now, hopefully this is all a recap for yourself, but essentially, don't panic, just do an A to E. And that's the case even for myself now. It doesn't matter if you're in a medical ward or a surgical ward, really. If someone becomes unwell, you just need to bring it back to A to E. So go and assess the patient, have a real think, and hopefully this is things you've been over at medical school. So talking about airway, breathing, circulation, disability, and exposure. Now, your vascular patients predominantly are going to have most of their issues in the circulation section of this. So normally airway and breathing is normally okay, unless you've got a post-op patient who might perhaps have an infection, for instance. And don't forget, in disability, never forget glucose. Often your patient's going to have diabetes on the vascular ward, so it's really important you do that. And exposure, often these patients are either going to have had bleeding, be prone to bleeding, or prone to clotting. So you really need to expose the whole patient, look at surgical sites, and make sure you examine those calves. Okay, so a little bit more detail here. So don't forget in your breathing, if you're assessing a patient and they're acutely unwell, put them on 15 litres of oxygen until you've ruled out that that's, not a problem. I'd rather you have a patient on 15 litres and then you say, oh, it's not an oxygen issue, we'll wean them down, than you go through everything and at the end think, oh, I'll put on 15 litres. Yeah, so let's start with that. Think, do you need bloods whilst you're doing this? Have you got a colleague? Can you ask for help? Fundamentally, if you're doing an A to E and you're escalating early to your seniors, you can't go wrong. Now, often you'll have an SHO, a core surgical trainee, someone on the ward with you. But even if you're on your own, don't be concerned about phoning your registrar. If you've got someone who's unwell, they'd rather know early than you tell them, when you've been waiting around for half an hour, for instance. In vascular patients, half an hour is a long time for, if you're thinking about a limb or something like that, if they need to go to surgery, half an hour can be a big difference. Okay, so GCS, just recap this. I'm not going to go into detail about this today, but often when your patients get unwell on the ward, if you're then going to escalate to ITU, which may be the case if you've got an unwell patient, they're going to want to know GCS. And the reason I've got this on here is a reminder, don't just say a number, have a breakdown, because ITU will want to know, what are you scoring for eyes? What are you scoring for verbal? Because, a score of 12 could be very different in different areas to create that number. So that's really important and allows people to compare from one day, 1 hour to the next. Okay, 99% of your bleeps on call aren't surgical. Now, take a moment to accept that. If you're the junior on a surgical firm, most of the time you are medicine on the surgical firm. So there's a few areas here that in my experience when I've done vascular on calls, these are the areas that will cause you the most amount of headaches in the evening. And they're the ones that I would recap and have a look at your local trust guidelines. Hyperkalemia. Now, a lot of your patients will have had renal problems, often they're CKD patients, and those patients are very prone to having a high potassium. Equally, if you're giving someone blood products that has a lot of potassium in it, have a look at your trust guidelines. Essentially, you're giving them, say, salbutamol nebs, calcium gluconate, insulin dextrose, and then you need to repeat VBGs to check, is that potassium coming down? And do you need to escalate? Is the patient, for instance, eligible to go to ITU? And do they need renal replacement therapy? These are things, as a junior, you need to be picking up on. Again, sepsis, You would have gone through this lots at medical school, so I won't go into that today, but sepsis 6. Hypoglycemia, what do you do in those patients? And there should be a glucose box on your ward, and the nurses are normally very good at escalating this to you and starting the management themselves. But essentially, are they well enough that they can have something oral? Are they too unwell? Is their GCS too low, or are they nil by mouth, and do you need to give something through the vein? Hyperglycemia. Now, this often causes a bit of a headache on the ward. Again, have a look at your local guidelines. Obviously, if it's extremely high, greater than 30, are they acidotic? Are they type 1? Have you got ketones which are high? Those are the things you need to be asking your nurses. Blood ketones, often they won't have the machine on the ward, so think about urinary ketones if not. Make sure you have that. All of these problems are going to be escalated likely to the med reg rather than your surgical registrar. Now, often it's, the polite thing to do would be to let your surgical colleagues know and say, I think I'm going to call the medical registrar. Are you happy for that? Obviously, if a patient's unwell, you need to escalate and put out. In my trust, it'd be called a MET call, so a medical emergency call, or a peri-arrest if they're very sick. You usually get in that medical team straight away. Okay, and chest pain. Don't forget, troponins will often be raised in other problems. For instance, a CKD patient will have a high troponin. So have a think. Does your patient actually have chest pain? Take appropriate history, get an ECG, and then if you think that it's chest pain, then do a troponin. But remember, then you're going to need a second troponin, and then you might need to be calling cardiology. So think about that. Okay, moving on to the surgical bits, because that's what you're here for. So clinical scenario 1, you're on call, you get called to resus to clerk a 55-year-old male with back pain. Now, likelihood of this happening is slightly slim if you're an F1. Hopefully you won't be going to resus to clerk patients. Often the SHOs or perhaps even the surgical reg would be seeing this patient, but say they're in theatre with someone else and you've been asked to go down. You take a history, it's sudden onset, it's tearing, they've had some analgesia, but it's not getting on top of it. And actually, whilst you're talking to them, their GCS drops, okay? You look at their cardiac monitor, because if they're in resus, they're often on a monitor. And you see that their blood pressure starts to drop, and now it's 82/56. What are you worried about? Now, there's a few red flag things you should always rule out. In this history, it should be pretty clear to you. We're worried about a AAA, okay? So I'm talking about abdominal aortic aneurysms. And in this case, we're concerned that it's ruptured by the fact that they've become hemodynamically unstable. On the right, you can see a CT image, and you can see that the aorta has an area around it, which is an area of fluid. That is the rupture. Now, if you've got someone who is unstable, then that patient actually should be missing the CT part and be going straight to theatres, and you'd be escalating immediately to your registrar to facilitate that. Now, quick table here for you to look at. So you've got your symptoms, you've got your investigations, and you've got your management. Now, if you've got someone who is hemodynamically unstable, you need to be thinking about permissive hypotension. Now, what I mean by that is if your patient is talking to you and their GCS is kind of maintains, you should not be giving them lots of fluids. Now, the reason, because really with these patients, you're hoping that their natural body's kind of coagulation mechanisms are going to be trying to clot off that rupture. If you push lots and lots of fluid into them, there's a risk that you're going to dislodge that kind of clot that's already forming. You're increasing their blood pressure, and in the process, you're potentially making that rupture worse. So if they're talking to you, if you're happy that they're getting enough blood flow to their brain for them to be able to have that conversation with you, don't aggressively give them fluid, okay? Now, if you're seeing them in A&E, that's a good sign, because actually a third of these patients are going to die before they even get to hospital, okay? The ones you see in hospital, half of them are still going to die. So actually the mortality risk is massive in these patients, which is why you really need to act early. If you're the junior, the things you need to remember for this is escalate early, do your A to E, be quick about it. They haven't got a lot of time, these patients, and things you can do to help your seniors. So you want to make sure this patient's got 2 IV access, ideally both antecubital fossas and a large bore, so a green or a grey cannula. You want to make sure that you've taken bloods. You want to make sure they've got a grouping saved. This patient's going to need blood products. So you need to make sure that you're telling the transfusion lab that you need units. Potentially, they may need O negative if you can't cross-match that sample quickly, okay? These are things you need to remember. Okay, so just a brief overlook for yourself. Essentially, you have two different classification systems, Stanford and DeBakey. Now, they sort of overlap to a degree. Your type A Stanford classification patients normally dealt with by cardiothoracics. Now, that's because we're talking about the aortic arch. They're going to need an aortic root repair, and that's something that needs to be done inside the chest. Those patients will get a midline stenotomy during surgery. If you're talking about your type B Stanford classification patients, they have a rupture more in the abdominal sort of area, okay, so below the diaphragm. Some of them also have an element above the diaphragm. You'll need to liaise amongst cardiothoracics and the vascular team. But type B, for the most part, is vascular surgery's domain. So you're going to be seeing type B for the most part, but be aware of type A. So what do they do? So your options in AAAs are either do nothing. Now, you might say, why? Well, if you've got someone who's, say, 90 and frail and has COPD and cancer and all of these other conditions, well, chances are they're not going to be fit for the anaesthetic to do any of this. And that might be the nicest thing to do, to actually make them comfortable, get their family in. So that's one option. Surgical options, you've got interventional radiology. Now, can IR, when they look at imaging, which hopefully you've got if the patient's stable, go in and put what you can see is this mesh on the left-hand side of your screen, hopefully. Now, they go in and they blow that up and expand it. So you've got the aneurysm on the outside, but now you've got a new pathway for the blood to flow. And often that works very well, has very good outcomes, and you're only needing to make one sort of entrance within the normally the femoral artery. Okay, so that's quite useful. Now, on the right-hand side, what you're seeing is an open repair. Now, if someone's hemodynamically unstable or it's complicated and interventional radiology don't think they can do it, then you've got to do a midline kind of laparotomy, open up, and vascular surgery will have to go in. They have to clamp above and below. They're having to remove that area and replace it with what you can see here, which is a mesh. It almost looks like a stocking material. And if you've got the branches coming off of the aorta, then you need to have like almost like trousers, like extra areas coming off. Okay, so be aware that's what that looks like. Okay, scenario 2. Let's change it up. So we've got a 25-year-old. They've got a background of Ehlers-Danlos syndrome and they've had a road traffic accident. They come in as a trauma call and you go as part of the trauma team. During the primary survey, patient has neck pain because they've had whiplash within the car, and you notice within D, so when you're looking at their neurological status within the A to E, that they've got one dilated pupil, and you can see on this image on the right side, got dilated pupil. And on top of that, they're having problems with speech, they're having problems with motor function within their limbs. Now, what's going on? Now, this is a little bit rarer, but something to be aware of. Carotid artery dissection. Now, in your carotid arteries in your neck, especially young patients, especially patients with connective tissue diseases, where the actual, the wall of the vessel itself is a little bit weaker, they're prone to having a dissection. Often, if they don't have neurological symptoms and it's just a finding on CT, you will just treat them with antiplatelets because you're trying to reduce the risk of a thrombosis being thrown up from that aneurysm and causing a stroke. So you're quite conservatively managing that. Now, if they've got neurological signs of a stroke, signs of Horner syndrome, which in this case this patient has, then it's already too late just to give someone conservative management. In that case, you're thinking about whether or not the patient needs to have an IR or a surgical procedure. And essentially, they're going to be going in an angioplasty. So the same thing with going in and blowing up a balloon with a mesh tube. So that's a new wall and a new vessel there for them. Or potentially you can go in open and replace it, okay? Now, acutely painful limbs. This can come up in A&E, but can also really come up on the ward. And I really stress this to you. I've had so many patients, medical wards, surgical wards, with painful limbs, and it can be missed, the severity. Now, DVTs. This is something you should be looking at every day on the ward rounds. Almost monotonously, you're going to be doing a cardio exam, a resp exam, and you're going to be looking at someone's calves to see whether they're swollen, whether they're painful. I would stress that every day, because your patient's already immobile, they're in hospital, they're unwell, they're often dehydrated because they're in hospital. They've got high risk factors for developing a DVT. Now you can see in that image that that patient on their right leg, that calf is hot and swollen. Now, if you see that, your suspicion is that this is probably a DVT. If you've got a high suspicion of a DVT, then you need to go and order a Doppler, a venous Doppler of the leg, okay? And then you can speak to your vascular team depending on what comes back, okay? However, if your suspicion is, oh, I'm not so sure, it could be something else, the patient's got perhaps heart failure and it doesn't look that asymmetrical and maybe it's not red, then you might want to do a D-dimer and then think whether or not you need to actually do a Doppler, okay? Essentially, the Dopplers are really easy to get done in hospital. So if your threshold, have a low threshold for suspicion because they've got risk factors often, okay? You're going to treat them with low molecular weight heparin whilst they're in hospital, and often you'll start them on a DOAC for a few months afterwards with an anticoagulation clinic on discharge. However, some patients develop a DVT, which is higher up. It's not in the calf, it's actually the iliofemoral junction. So we're actually talking about then the deep venous system. If that is the case, you need to actually be discussing with your IR colleagues. Now, the reason is because you're obviously then obstructing the entire venous drainage of that limb, and that's more of an urgency behind that. And you need to be speaking about IR, whether or not they can go in and try and break down that clot directly in the lab, okay? In the upper limb, you can get an axillary vein thrombosis. It's similar. You also need to speak to your IR colleagues about breaking that down, okay? And that's with IR-directed heparinization, okay? Fine. Then moving on, clinical scenario 3. So you're on call and you've got some post-op patients on the ward, and one of the patients is a trauma patient, maybe seen by orthopedics, and they've had an open repair of a fracture. And the nurse says to you, oh, their leg's really painful. And I've given the Uromorph on the PRN side of the chart, but they're still complaining of pain. Could you come and see them? Could you prescribe something else? Now, if a nurse is saying to you that someone's not actually responding to Uromorph or morphine or strong medication, I would have a low threshold, especially in fracture patients, to really going with some sort of urgency to go review that leg. Now, in the back of your mind, you should be thinking about what problem this could be. Now, do you panic? Do you go to have a look for a handheld Doppler because you remember from my previous lecture that's something you should be looking for on the ward? Do you phone your seniors? Do you try and find an SHO? Do you try and just give them some more pain relief? Do you go order a CT scan? Or do you just think, oh, I need to prepare this patient for theatre? Now, an element of all of those is true, but go and assess that patient. Do your A to E, like I said at the start. Do your A to E and make a decision. What's your impression, okay? Now, the thing we're worried about is, could this patient have an acute ischemic limb, okay? Now, these patients will have described to you, oh, I've got incredible pain and my leg looks a little bit different. It looks a bit pale, or the nurse has noticed that it's a bit paler, okay? They, after a while, will say to you that the sensation, pins and needles, or they can't feel it at all, and then the limb's cold, okay? The sensation aspect and the cold limb, or the inability to move that limb, is quite late on in an acute limb ischemia. And if that's the case, then actually that's quite bad, because those patients, if you have a look at this table at the bottom, are most likely going to end up with an amputation rather than you being able to salvage the limb, okay? Now, if someone says you've got an acute painful limb on the ward and they've got risk factors like a big fracture or something that you think actually there could be a clot, okay, a fat embolism or an obstruction, something affecting the arterial supply, if you can have a Doppler and you know where it is, that's a really useful thing to see whether or not you can you can get pulses, you can get a sound back to you that you think, okay, this person's got some phasic flow, okay? However, don't let that delay you escalating to ischemia, because actually you rummaging around trying to find the Doppler on a ward where you might not be able to find it is going to delay time this patient getting to theatre. Now, often this patient, what you'll need to do is escalate to your seniors who will come and review, but you might also need to be ordering a CT angiogram kind of at the same time, really. Often your vascular colleagues might be in theatre. Okay, so you'll call them, you'll let them know you really want them to come review because you're worried about an acute limb ischemia. Okay, and you've assessed the patient and you tell them the history. Okay, what you need to do at that point is have a look at the patient's renal function. If you need to do a CT angiogram, that patient needs to have good renal function to have the contrast. Okay, if their eGFR is very low, you might need to be having a discussion with your radiology colleagues about what alternative options you have. Okay, now, if this is an upper limb ischemia, you are going to need to potentially prescribe IV heparin whilst you're making a plan, because you want to try and break down that clot to try and save that limb, to salvage that limb. You can have a chat with your IR colleagues, tell them that you've got an acute limb ischemia, you're sending them for a CT angiogram. Can they look at the images for you? Okay, if they can and they can have a look, they potentially could do angioplasty. Now that's again the balloon maneuver with the mesh kind of vessel that it's going to create, so a new passage. Now that's really useful. Potentially this patient, however, might need a graft, and if that's the case, often it's the long saphenous vein that they need to take. They reverse it because of the valves that are in there, and then they will then plug that in, so you've got a system where there's a bypass. Okay, so the conservative management again is another option here. If you've got an elderly patient who is frail, they have other comorbidities, is this the most appropriate thing to put them under a general anaesthetic to see whether or not you can do a graft, a bypass graft? They might not have healthy vessels for you to do a bypass. You might have to use tissue grafts. You know, at that point, you need to have a discussion. Does this patient want this? Are they safe to have it? Should you be potentially palliating them? Now, if you don't treat this, the limb will become necrotic, they will become septic, they'll go into multi-organ failure and they will die. Okay, and it's extremely painful. So, revascularization, you will hear vascular surgeons talk about runoff. Is there good runoff from that limb? What they're talking about, if it's the lower limb, is what you can see here on the right hand side of your screen, labeled 1, 2, and 3. Have they got the anterior tibial? Do they have the peroneal or fibula and the posterior tibial? If they have those 3 vessels, and during the CT angiogram they are patent, they are working, you've got good 3 vessel runoff. If 2 of them are working, you've got 2 good vessel runoff. That's okay, it's not great, but it could be worse. If they don't have good vessel runoff, you creating a new plumbing system by creating another vessel, using a long saphenous vein as a graft, for instance, or a bypass, is not useful, because actually there's a blockage lower down. If that is the case, the patient's probably more likely going to end up with an amputation. Okay, and obviously you want to save as much of the limb as possible, but if there's not a good blood supply, you need to take that into consideration. And ultimately, just be aware that the vein grafts are going to have a better outcome than prosthetic, so a PTFE graft. However, you know, if you haven't got good veins, then you're going to have to use a PTFE graft. Okay, now you might be thinking, if you've got a painful, acutely painful limb, well, could it be compartment syndrome rather than an acute limb ischemia? Now, the difference is very subtle, I guess, in textbooks. So your 6 Ps you'll have learnt about, is your pain, your paresthesia, paralysis, okay, perishingly cold. All of those Ps are the acute limb ischemias. Now, if you've got compartment syndrome, eventually you can get acute limb ischemia, so there is some overlap there. But with compartment syndrome, what you're initially getting is that swelling within the fascial layers. And initially it will compress the veins, then it will compress the nerves. So that's when you get the paresthesia. And then it will compress the artery, which is when you start to get the acute limb ischemia. Compartment syndrome will normally present with horrendous pain, very similar to acute limb ischemia, but it's worse on passive stretch. So if you've got the lower limb, you stretch the ankle. If they are in agony, then think, is this compartment syndrome? Is the leg swollen? Have they got a history that would be in context? Have they a burns patient? Have they had lots of trauma to that area? Have they had surgery? Okay, if you're worried about compartment syndrome, what should you do as a junior? Well, A to E, escalate early. Those are the two things you need to remember. However, if you've been in the vascular team for a while, you've got a bit more experience, you may be aware that there is this device on the right-hand side of your screen. Now, that is to measure compartment syndrome. Now, essentially, it's a green needle that you introduce with a syringe that's got a pressure gauge into each compartment, and in the lower limb there's 4 compartments, and you measure the pressure. If that pressure is above 30 millimeters of mercury, that is a sign it's compartment syndrome. However, that test itself as a junior, you're probably not going to get much experience using. And if your clinical suspicion is there, then you need to be escalating to your registrar. They might come and do that test. They might say, you know what, if we're worried about it, this clinically looks like compartment syndrome, then they're going to do a fasciotomy, okay? Now, fasciotomy, you can see, and apologies if you're a bit queasy, on the left-hand side of your screen, in the lower limb, 2 incisions, and there is 4 compartments. And you might say, well, why isn't there 4 incisions? Well, if you have a look in the middle image, what you can see is you've got your 2 posterior compartments, you've got an anterior and a lateral. Essentially, one of your incisions will go through 2 compartments and the other incision goes through the other 2 compartments. So even though you've got 2 incisions, it is opening 4 compartments. And on the right-hand side of the screen, you can see what the patient ends up really being left with, which is quite a large opening, but normally plastics can help put skin grafts eventually on there. And ultimately, you've saved the limb, so they've got function in that, and that's important. Okay, it's urgent. You're worried about the fact that afterwards, and your patients you're going to be seeing on the ward, their renal function can go off because of rhabdomyolysis. So please be aware of that. You're releasing all of this breakdown products because the muscle has a period of ischemia, and then your kidneys can get really unhappy, and you might need to be speaking to ITU about doing renal replacement therapy for a short period during that. Okay, amputations. Amputations, essentially, you'll get them in an elective setting, often for your ulcers. You'll get them in the emergency setting. Now, just be aware of them so that when you're reading notes, you understand. For instance, a hip disarticulation would be up, the most severe form of lower limb amputations. And then you've got above knee, a Gritty-Stokes, and a below knee amputation. Now, often the below knee amputations will give people the best chance of getting a prosthesis. That's the most natural, and they get on with it. Above knee often needs to be done because there isn't good supply below the knee. And often it's a bit of an easier surgery to do. However, the above knee, especially in over 70s, doesn't tend to get a great prosthesis fit on it, and often they won't be able to then use that limb the same way. Okay. Clinical scenario number 4, one of the last ones. So an 88-year-old comes in with atrial fibrillation, dementia, falls, CKD stage 4. Now, ultimately, aging population at the moment, this is going to be a lot of your patients coming in, lots of comorbidities, they're older. And she's been in a nursing home and she's had some abdominal pain, and they've tried giving some of her tramadol that she has, and she's not responding to that. And she had one episode of bloody diarrhea, so they called an ambulance and she's come in. And you go and see her and you think, okay, well, her blood pressure is not great and she's tachycardic and I'm worried. What do you do? Now, hopefully you're at home thinking, okay, we've had this enough tonight, Kat. So you're going to do your ATE, you're going to escalate to your seniors. But the things I want you to remember is acute mesenteric ischemia. It's not too common, but it's really easily missed, so easily missed. You've got a patient in this scenario who has atrial fibrillation, they've had lots of falls. They might not be on a DOAC or anticoagulation because of the falls. And so they're sitting there with such a high risk of throwing emboli. Now, if that emboli goes into the GI arterial system and blocks off, that's quite commonly will cause this acute abdominal pain. And what do you do about it then? Well, either you're going to do the CT abdo-pelvis and with the IV contrast and see exactly where that blockage is and speak to your IR colleagues who are going to come and remove the clot like they would do in a stroke patient. Or you're going to do surgery and remove the non-viable bowel. And you can see on the right-hand side that dusky area. Now, they're great options if you've got a young patient and they've got reserve. In an 88-year-old with atrial fibrillation dementia, she probably won't, well, it depends how severe the dementia is, but she might not be able to consent. And she's got CKD stage 4. This is quite a big operation, and you're thinking about putting a stoma, removing quite a large piece of bowel. Nutrition is going to be an issue that's going to have a long ITU stay. That might not be appropriate. So please do think about whether or not things are more appropriate. And obviously your registrars will be making that decision, but as a junior, you should be advocating for your patients and you should say, I've actually thought about this. Should we be doing surgery in these patients? And the gold standard is a CT abdo-pelvis, IV contrast. She's a renal patient, so we might not be able to do contrast. These are the things you need to have in the back of your mind. On the right bottom, there's a QR code, which is quite useful. It's a nice paper, I think from 2016 on acute limb ischemia. I'd really recommend looking at that. Okay, so that's the end. I've only got 5 minutes remaining. Try to keep it short and sweet for you on this hot evening. Hopefully this isn't you learning from YouTube, but ultimately I'm sure it will be if you're watching this. I'm sure you'll do very well. And there's a little QR code there if you wouldn't mind giving me some feedback. And is there any questions? Perhaps not.
No questions. Thank you very much.
You're very welcome.